donor maintenance was covered, the surgical aspects and the anesthetic aspects, almost all of them are covered. Now, what I'm left with is practical difficulties in disease donor transplant from our perspective, that is the nephrologist perspective. So, over the years, the biggest challenge we as a transplant community is facing is the stats on the right side. It all started so well in 2012. Fortunately, I was also a part of the team. Actually, I was incidentally the PG or the resident on call on that day when actually the first transplant, the disease donor transplant, happened under the aegis of KNOS. Noble Source obviously took the leadership role in that transplant. That happened in Trivandrum, and the next day another transplant happened in Kozhikkodu. So it was all going well. And we can see up to till 2016, it was all going well. In 2015, the number of transplants went up to 218, and actually we overtook Tamil Nadu in that year. But then suddenly the things took a worse turn, and you can see the number of transplants over the years is coming down so drastically. So this is the biggest challenge that we are facing now. So coming to the role of a nephrologist. Actually, in many centers, the nephrologist, along with the transplant coordinators, when they are informed by the KNOS or by the team, actually if it is a donor from their own unit, they are the first people to get involved. And when the deceased donor's family is showing some willingness to donate the organs, they are the first people to get involved. And the team of this particular team has got the responsibility to bring together the whole transplant team who are more important in the process, like the surgeons, the anesthetists, the intensivists, the radiologists, the harvesting team and transport team, and the implant team. And meanwhile, parallelly, there has to be a mechanism by which the recipients, the potential recipients, are to be alerted that they will get a call if everything is going well. And meanwhile, an immunological laboratory also has to be in advance. They have to be informed that this much of pairs will be coming for a possible cross-match on that day. And we know that almost all these things happen in the middle of the night. Most of the transplants happen in the middle of the night. And clearance for all from various departments, especially we know that the recipients cannot be well worked up in this case. So all of a sudden the cardiologist will come into place, the pulmonologist will come into place, so that the recipients are given clearance. This is a brief process, how the things are going on. What is happening in the recipient side, the donor side, everything put together. The information regarding the surgery will be passed on to the surgical team and the anesthesia team, and we have to cross-check the readiness of infrastructure in our facility, that the operation theatre is ready, the transplant and nurses are ready. So everything, all the equipments, the instruments, everything has to be ready. And meanwhile, from the list of KNOs, we have to check for the matched or the potential recipients in the group, and we have to, and we actually call them not 1 or 2 or 3. The problem here is that most of the recipients may not be ready for an immediate transplant. They may not be mentally ready, they may not be physically ready, they may not be financially ready. So the role of transplant coordinator comes there. He will have to make a call to at least around 10 potential recipients, ultimately to get some 2 or 3 donors, recipients. Then meanwhile, parallelly and more importantly, donor organ safety, which is the ultimate end result of a good organ donor maintenance, and critical care team plays the most important role there. But many centers may not be having enough critical care people, and that issue is already dealt with. And many a time, the nephrologists, the residents in nephrology units, they are becoming the intensivist in that scenario. And meanwhile, the nephrology team or the surgical team has to have a good donor evaluation so as to minimize the complications and arranging organ harvesting and safe transport. KNOS has solved many of the issues regarding that, and recipient selections and preparations are to go on parallelly. The golden 6 hours. There are some controversies in this topic. Actually, sometimes the donor side, once they know that the relatives come to the fact that the patient is not going to be recovered, in that case, they may come and volunteer to have all his organs donated. And in that scenario, that golden 6 hours can be utilized. That is the 6 hours between the first apnea test and the second apnea test. And in this time frame, we can have a donor workup and a facilitation for transplantation. Police and forensic intubations can be sent, and post-organ procurement formalities can be planned. And this is only possible in that scenario. And coming to the donor action, first thing, how the donor is identified. It's obviously by the intensive care team. The neurosurgical or neurology teams will identify the potential donor, and they will, along with the medico-social workers, will do the first preliminary briefing to the relatives. And if they show the willingness, then we will be proceeding fast. And brain death certifications are usually done by the KNOS and empanel team. And the screening of donor has to be screened for many things, like his volume status, the hemodynamics, the presence of infections. Are there any indication, any conditions in the patient which actually works against organ donation? And counseling of donor family will be done by the medical social workers as well as the treating team. Actually, the treating team plays the most important role there, and the surgeons, the nephrologists have no place in that aspect. And maintenance of donor is always by the critical care team, and this is one of the most important steps in getting quality organs. And being with the donor family at the time of their deep sorrow is also a part of the treating team as well as the nephrology team who are attending this case. And this is what is happening most of the time, denial of consent. We know that all the brain deaths may not be certified, and even though they are certified, sometimes the consent may not be given by the relatives. First is their non-acceptance of brain death, the traditional concept of death, that is heart is not pumping, the pulse is not there. That is considered as actually the definition for death for many. And there can be concerns about delay in funeral and disfigurement. Then lack of consensus within the family. Some may be very, very pro for this donation, but some members, if they show a sort of opposition, then this will have to be dropped. And sometimes the relatives may not be satisfied with the hospital staff that can work against donation. And obviously, of late, in our state, particularly over the last some years, there is a fear of organ trade happening behind this. And there are religious beliefs and superstitions which stand against donation that we all are aware of. And this is a concern which has arisen over the last 2 years. That is fear of denial of treatment to the diseased to extract organs. Actually, the conversion of a healthy one to a diseased donor. And in any of these phases, the nephrologist should not get involved. Coming to the donor maintenance, it's already well dealt by Dr. Ganga. Actually, donor preservation centers with no dedicated ICU team and exposure is a challenge, as we have found out recently in Palakkad. And this happens most of the time in the non-transplant centers, which may be just an organ retrieval unit. And here we have to ensure the hemodynamic stability and hydration status. And in most of them, the diabetes insipidus state happens where the deceased donor will be excreting a lot of diluted urine and resultant hypernatremia, which actually works against a liver extraction. And sometimes they need anuric, and there can be a rise in creatinine. This is most probably due to inadequate volume status. And here also an important role of the treating team. As very well suggested by some of the members here, a dedicated organ maintenance unit run by KNOS can be a boon, and these units may be placed in each zones, and this can be under the aegis of our Ardram scheme, which is a landmark scheme in the history of Kerala. That can be done, at least dedicated organ maintenance units run by KNOS. Then steps in donor evaluation, and parallelly the donor has to be evaluated for extraction of organs. A blood group anyway has to be cross-checked again. Presence of infection. If it is a treatable infection, most of the time our aim is to extract maximum organs, or the threshold for organ rejection should be actually high. So even though there are some infections, it is not a bar for donation. Hemodynamics and volume status has to be maintained. Then coming to the renal function. If we know the renal function, the baseline renal function, suppose the patient has developed a state of hypovolemia and he has gone into stage of pre-renal state or 18, we know that potentially it is recoverable. So the renal function, even though it is somewhat impaired, it doesn't preclude an organ donation. Then cross-match samples are to be obtained. HLA sample, if it is available and a lab is there to do it, then CME antibody status, because that helps in planning the recipient CME prophylaxis. Coming to the screening donor, all the microbiology reports are to be pulled. Occult bacteremia and genitourinary infections are to be ruled out, and they generally preclude an organ taken, especially kidney with a genitourinary tract infection, especially pyelonephritis, is not a good organ to be transplanted. And one has to screen for bloodborne viruses, and not enough time for nucleic acid tests. And with simple ELISA, sometimes we may miss HBV and HCV in window, and donor-associated bacteremia is there, and we know that it is a treatable, it's a non-MDR pathogen. Then the recipient has to be treated for around 14 days minimum. And when there is active fungal infections in the blood and urine, or unspecified viral infections and encephalitis, it is better always to reject the organ. And because we don't know what sort of entity is it, that's the issue. And in this era of MDR club, we know that many of them are resistant to carbapenems, and the only drug that is available to us may be a colistin, which is potentially nephrotoxic. And we know that sometimes a colistin induced nephrotoxicity may not be reversible. So in that scenario, it is up to the housing team to decide whether this organ has to be implanted in the next recipient. And this is a broad classification of donors. Donors without much risk factors is termed as standard criteria donors. Expanded criteria donors are or otherwise known as marginal donors. And then the third entity is donation after cardiac death. But this third group doesn't come into place in our scenario. But this is one group from which maximum extractions are happening in Spain and other countries. Here the thing is that immediately after the cardiac death, the organ perfusion has to start. That's an issue. And coming to expanded criteria donor, in age more than 60 years, or those with above 50 years but with two additional risk factors like hypertension, death due to CVA, or raised terminal creatinine. That is the creatinine just before the organ extraction. And as said earlier, the threshold for rejection of organ has to be set high, and a pertinent question always comes: till what creatinine we will be able to extract the kidneys and use in the patient? I think the principle of having a baseline creatinine which is normal and has deteriorated with fluid depletion, and it has gone to around 3 or 4, may not preclude a organ extraction. But it differs from centers to center, and some centers may altogether reject kidneys with a terminal creatinine of about 2, and some centers may accept it, and obviously they have got good results according to their long-term stats. And coming to the perfusion of the organ, as Sreejesh sir has already told, it can be called static perfusion or pulsatile perfusion, but at any point of time, the studies show that pulsatile perfusion is better, and it gives a good idea about the transplantability of the organ, because high resistance flow in the perfused organ means the organ may not work in the recipient. we don't have a facility for that, and I think KNOS is in the process of doing it once the transplant this thing is picking up. Then this is the organ procurement order, as Sreejesh has just told. First is going to be the heart and lungs, then comes the liver, intestine and pancreas, then finally the kidneys. So we are left with the final organ, that is the kidneys are subjected to the maximum cold ischemia at time. So that actually puts the patients or who are potential kidney recipients at a downside. But that is not the case always, because this is based on the tolerable ischemia times. From this chart, it is very well seen that the heart and lung has got the minimum tolerable ischemia times of 6 hours, and so it is justifiable that the heart and lungs are removed first. Then comes the liver, intestine and pancreas. The liver has got a cold ischemia time of around 6 to 10 hours, and intestine has got 6 to 12 hours, and pancreas 12 to 18 hours, and kidneys up to 24 hours. But generally, it is the a transplant center can decide whether they have to accept organs which are beyond 24 hours. But many centers actually accept it, and generally the tendency is that if it is exceeding 72 hours, it be rejected. Coming to organ transport, once the organ is recovered, then it is transported by the transport team. And first is the pulsatile perfusion using either cold or normal normothermic perfusions. This is usually a cold static perfusion, and these are two solutions, HTK versus UW. And the problem is that both these solutions are costly, and if you are going to use 4 liters of fluids of HTK as well as UW, it is going to take another 1 lakh rupee from